Good day, everyone. Welcome to the webinar for us to discuss ways to accelerate progress toward hepatitis elimination in the Americas. Next slide, please. I'm Dr. John Ward. I'm the director of the Coalition for Global Hepatitis Elimination at the Task Force for Global Health here in the United States. I welcome you all to the webinar. It's our pleasure to be presenting the webinar in 3 languages: English, Portuguese, and Spanish. Most of the presentations will be in Spanish, but for those of you who have not participated in a Zoom webinar before, please just look at the bottom of your screen toward the globe interpretation, click on that icon, and then select the channel of your language. We will be recording this webinar in these 3 languages so please tell your colleagues that this information will be available in their preferred language after the webinar for those who are unable to attend today. For those who are not familiar with the Coalition for Global Hepatitis Elimination, we are a community of practice seeking to bring together all the stakeholders needed to achieve elimination for viral hepatitis around the world. We do that by bringing people to share lessons learned, which is what we're doing today in this webinar, providing technical assistance and information on country dashboards for over 190 countries. And through all of this, seeking to elevate and make everyone aware of everyone working on hepatitis globally so that we can engage even more partners to build the capacity needed to reach our goals for hepatitis elimination globally and in individual countries around the world. Next slide, please. This is one of a series of webinars that the coalition.
Uma série de webinários que estão aqui, que foram trazidos para os programas a serem compartilhados e ajudar todos a trabalharmos juntos com nossos metas comuns com hepatites e também oferecendo a mortalidade prematura no tratamento. As áreas incluem, temos a vacinação, principalmente para os recém-nascidos, e também para a transmissão, agendando o programa e se tornando algo mais eficaz em alcançar para a eliminação da hepatite. E todos esses webinários estão no nosso website, que são oferecidos aqui. O programa todo estão aqui, slides que tem um resumo dos capítulos de todas as apresentações.
Including these webinars, and you can also follow us on Twitter for that information, as well as various news reports that we put out as well. Next slide, please. One of the areas of work that we have been doing is developing national profiles to capture the status of hepatitis elimination at the national level, to really reveal the policies, the plans, the programs, the partnerships that are being brought together to achieve hepatitis elimination in a country. You know, what have been their achievements, what's their challenges, and what's their feasible next steps. We have, next slide, please. We have done this as a first stop in the Americas over the summer of this year in collaboration with partners in 6 countries in the Americas, as well as the Pan American Health Organization. These profiles are available on our website, and you'll be hearing from 2 of the countries that have these profiles later in this program. But it really sort of sparked the opportunity to build local coalitions in these countries between civil society, expert clinicians, ministries of health, which we did, but then also to see how we could begin to let others in the Americas know about this type of process of coalition building, information sharing, identifying feasible next steps that make hepatitis elimination more achievable as we all work together and look at to see what are reasonable next steps to achieve our goals. Next slide, please. So that's really, our objective here today is to extend that discussion to see how we can advance progress toward hepatitis elimination by sharing lessons learned, seeing what's possible, what are the challenges, and how we can work together to overcome them. Next slide, please. So it's my pleasure this time to turn it over to two of my colleagues who I enjoy working with very much, and I'm sure you'll be enjoying hearing from them in just a moment. We'll have Dr. Marcelo Silva, who is trained in internal medicine and in hepatology. He is the director of the Hepatology and Liver Transplant Unit at the Austral University Hospital in Buenos Aires. He's also president of the Latin American Association for the Study of Liver Diseases. He's joined by Dr. Letze de la Torre Rosas, who's also trained in internal medicine and infectious disease specialist with additional training at the London School of Hygiene and Tropical Medicine. Letze is the Director General of the National Center for the Prevention and Control of HIV at the Ministry of Health of Mexico, where she's been developing and leading the national program for HIV and the elimination of hepatitis C. I'm very delighted that they'll be moderating this webinar, and I'll turn it over to Marcelo to kick us off. Marcelo.
Thank you, John. Muchas gracias, John. Next time, I'm gonna ask you to deliver your introduction in Spanish. You're gonna have a challenge there.
Yeah, I'll work on that for the next one. Yes, I promise.
Okay. Bueno, buenos días a todos. Un placer. Gracias.
It is a pleasure to be here with you. Thank you, John, for this invitation, not only to this webinar, but also to be part of this coalition. It is a great challenge for us as a scientific society to be part of these different plans that aim at having a that specialize in public health. We are going to have three different presentations today, and then we'll have a discussion with the different panelists. So the first presentation will be about Mexico, the elimination of hepatitis B in Mexico. It will be carried out by Letze de la Torre, who is a general director of the National Center for the Prevention and Control of HIV from the Ministry of Health in Mexico City. Then we'll have another conference called the How to Eliminate Hepatitis in Brazil. Dr. Karen, who is the coordinator of the hepatitis viral national program in Brazil. And then the third conference is called what do we need to move forward, to move towards the elimination of hepatitis C in Colombia. This will be presented by Dr. Cielo Rios, who is specialist of ITS, HIV, hepatitis from the Ministry of Health and the Social Protection in Colombia. We've invited Dr. Ruben Mayorga from PAHO, Maria Eugenia del Feo Moyano, who is president of the HCV Without Borders Foundation from Argentina. We have Dr. Patricia Vélez Moller, who is co-founder of the Guatemaltec Association for Liver, and Dr. Solange Gerona, who is the chief of the National Program for the Liver Transplant and the Central Hospital for Hepatology in Uruguay. So Dr. De La Torre, why don't you just go ahead and share your presentation towards the elimination of the hepatitis virus in Mexico. Thank you, everyone. Good morning, everyone. It is a pleasure to be able to share this dialogue, this space with you that aims at exchanging knowledge in this region. We believe that we have a great opportunity now. This is how we see it in Mexico, to eliminate hepatitis C. And this is thanks to the progress made on medicines, drugs that are really effective and that are changing the dynamics on protection and to protection of people from hepatitis B. In Mexico, since 1991, we've already started having treatments that were very long and not very effective. The antiviral treatment started coming in Mexico in 2014, but it wasn't until 2017 where in Mexico we had access to the drugs that have direct action against hepatitis. Now, the problem with this introduction of these drugs is that they were only available to third level, very specialized clinics, and they were these drugs were very expensive, which really did not allow to have a real policy towards the elimination of hepatitis C in the country. We had to face a lot of challenges, and so even people that had hepatitis C, if they did not have fibrosis or if they did not meet some of the requirements like age and comorbidities, they were not able to access this drug. It wasn't until 2017 where we started having 2019 where we started changing that vision. The National Health Program in Mexico is very complex, and each one of the institutions would do their own purchases of their own drugs, and that would be very expensive for everyone. In 2019, the whole sector reunited or gathered to talk about the strategies and understand the needs at national level to change this situation so that we can have a program that would be more universal and having a public health program or an aim of covering more people and also educating people on hepatitis, the different sort of hepatitis. Also, we do not want to generate silos. We know that hepatitis needs to be attacked with an integral vision where we include all of the different elements. We cannot think about an elimination of hepatitis without having programs that aim at the vaccination strategies, reproductive and sexual health programs, prevention programs, but also other elements that we know that are important, such as mental health, addictions, substance abuse, attention to people that are in jail, gender equality, avoid discrimination, and encourage inclusion. So these are the different elements that are very important when we want to eradicate this public health issue, including HIV, addictions, and TB. That is how we created a comprehensive program that is patient-centered. In this program, we have different pillars that are paramount for our program. We can talk about universal access to treatment and tests. So the first thing that we were working on is ensuring through this purchase program, this innovating process, to having the drugs at a more accessible price so that more people would have access to treatment and tests. This would be something that would happen throughout the country. The interinstitutional integration of actions and information was the second pillar because we needed to share information. Silos are not good for the country. We needed to change the perspective and changing the care, moving it from the third level to the primary care, where we give people access to treatments and tests. And also have a perspective from the region. Mexico is a very big, very diverse country where there are differences in each one of the states. We have 32 states in Mexico where there are differences in the sort of epidemics that we see in the country. And so knowing this diversity, knowing these differences allow us to know where we have to work the hardest. You can see on the map the really dark red areas where we have a rate of almost 49 inhabitants. And then we see the regions where the problem is the greatest. So we need to center our strategies on these areas. If we want to have a patient-centered program, we need to pay attention to the person. We need to include certain elements that would allow us to do so. We first realized that there wasn't enough information on hepatitis and viral diseases. This was something that both the practitioners and the population in general did not know this information. We need to understand why it is important to have an early diagnosis, because that would allow us to avoid problems in the future. So education is important and prevention is important. We need to go where the people are and also talk to the health professionals. But what we want is to avoid new infections. So we need to think about the other elements that allow this transmission, and also considering the current situation with the pandemic and the substance abuse. So we want to have people working towards the promotion of health. And through this strategy of primary care, we can allow people to have a rapid test. If this rapid test is positive, then we do the viral load sample and treatment to decide which sort of treatment the person will receive. And we will refer this person to a center, a health center. Before, we only had 12 centers in the whole country. I'm going to show you a map that shows you how this strategy changed the situation. If people have a steady condition, they can have this primary care attention. And if they have a more advanced disease, they go to specialized centers where they will be enrolled in a prevention of reinfection program. We have standardized information because really we want to have an epidemic intelligence. We did a lot of things to be able to attain this goal. We prepared the previous implementation of this program. We talked for instance, about the modifications that we needed to do. We trained the whole personnel that were working on this program. We sent tests and drugs to the different clinics. We did a presentation of this program to the governors and ministers of health of all of the country. And we signed agreements that allowed us to continue to move towards the goal. This is a work that we started in 2020 together with the pandemic. We needed to change our strategies. So we decided to start our work with a certain population, people with HIV. We decided to start working with these people because we already have a record of how many people have HIV in the country and that were participating in certain programs. We had the information and we were able to have a follow-up on these people. With that, we were able to roll out the implementation and have an escalation of the program, even though the pandemic was hitting the country. Then we started working on other aspects of the program. We started working with other sort of people, like people that were in jail, people that had a substance abuse problem, people with hemophilia, migrant population, etc. So the previous implementation phase has concluded, and the rest of the key populations continues to grow in the last months of this year. So the training program was an online training for the update on the diagnosis and early management of hepatitis C at the primary care clinics, with more than 100,000 people that were enrolled. And we were very happy to see all of these because we knew that these were people from the primary care sector. We had social workers, we have healthcare professionals that were taking this course. And then we also had people from the second and third level of care. And we had other people that enrolled on these programs. We have newsletters and we have uploaded also webinars on our webpage, and we carry out national campaigns that you can find on the radio, you can find on ads at the different transportation methods, so that we can support them. The mentorship program has been very important because it has allowed us to identify and to see a solution on the gaps, to have a forum to discuss the different cases, to talk about the different clinical cases, to identify the local leaders, to create regional groups, and to give mentorship online for different very complex cases, and to support, give support on the scientific production and research works that are so needed for this program. We have an automized center. It is a hotline where people can call us and we can get back to them and give them follow-up, because maybe they want to have a hepatitis C test, or they want to receive treatment, or if they want to talk about HIV and other sexual transmissible diseases. And with that, we can have data. The peaks that you see on the graphs at the right happen when we have the national campaigns. We understand that giving information and putting this information available to people allows for people to be more interested in these different topics. We would love to have a communication program that is that never stops, but we have to work on that yet. We have standardized information, a standardized information system that allows to identify the different progress on the different regions. We can see the impact that COVID-19 had on the triage that we did throughout our program. And with that, we can identify and we can give follow-up on samples of people and the risk factors at in real time, thanks to this platform. So it is very useful to have this platform, because with that, each state knows the status and they can compare their work to those of others. So I was telling you about the impact and the increase of centers for hepatitis. In 2019, you can see the green dots, where only in a few states we had centers where we could treat hepatitis C. But in 2020, with the changes that we made, we increased to more than 100 units throughout the whole country and in each one of the states. Each state has a clinic. There is at least one clinic, and sometimes even more, in each state that takes care of hepatitis C. And this improves access to people. And each one of the states today, we have given the example of the state of Oaxaca, where they have clinics that can do a rapid diagnostic, rapid tests. In Oaxaca, we have 347 centers for the hepatitis attention, where they can have access to this rapid test and this treatment. Can you imagine moving from less than 20 centers in 2019 to more than 300 clinics in only one state? So we understand that this is something that we can achieve. We've made also progress on the diagnostic of this disease. From each one of the different campaigns, we've really been making a lot of achievement. We are able to identify more and more people. And we know that in the past we did not have a sufficient diagnosis of people, and now we are able to do early detection of hepatitis C in people. This is the progress made in people that live with HIV. In some of the states, they've been able to reach all of the people that live with HIV and that receive treatment, and those who have a confirmation of the diagnosis. And so when we compare the results on the different states, we have a benchmarking, and with that, we can know how we can improve and we can learn from the best practices of the different states so that we can move towards the elimination of hepatitis in the country. So having this newsletter, and having this campaign, also, we can move towards the elimination of hepatitis C. We need a vision, and we need different cycles for the improvement and the innovations. We know that there is area for improvement. We're happy with the progress made, but there are a lot of things that are yet to be done. And that's why we're here, because we want to learn from you. We want to learn from the different states so that we can aim at improving our programs. The next steps will be the detection based on a model, a collaboration model with PAHO, the simplification of reports and platforms. We need to give information to the people so that they can make decisions to have a non-reactive rapid test for people at high risk and people that have received treatment, and also understand the reinfection risk and how can we have effective prevention programs to take care of people that haven't yet received treatment, to have a strategy to avoid infections, reinfections, and to avoid or reduce damages. We want to work with the indigenous population, the Afro-Mexican populations that are in different states. We believe that this is paramount. We need to understand why there's hepatitis C in these regions. And we also have a national observatory from the beginning of the strategy, and our plan was made up through the collaboration of different institutions. We meet every 15 days to understand what is being done in the different states, what can we improve, and in this national observatory, we have the participation of community leaders, the different health institutes, the national strategy for the prevention of addictions, the DGE, DGIS, DGTI, DGCES, CNTS, DGPPS, DGEGYSR, different leaders at the clinics, the different members of the academy, and PAHO. We have a group, a task force that aims at the reduction of damage that is working with specific populations. This is what we believe, and we are convinced that we need to work together. Coordination, inclusion of the different actors is paramount because it will allow us to move towards the elimination of hepatitis in the country. Thank you.
Bueno, Alexe, muchísimas gracias por tu...
Thank you so much, Alex, for your presentation. I am encouraged to see how many progress you've made in Mexico, because we are running out of time and we're lagging behind. We will move right ahead to the next presentation. And please check the chat because there are some questions for you. Could you please just respond to them? And let us move on directly to the next conference. So this will be about Brazil. Dr. Karen Tony. It says Karen Tony, but he said Cristina Ferreira.
Con Dr. Karen Tonini.
It is Dr. Karen Tonini, not Cristina. She is the directress of the National Hepatitis Program in Brazil.
Para un asistencialista como yo es un desafío poder ver como un programa como el SUS, ¿no?
We want to learn more about the SOS program and compare it to other programs such as the one in Mexico. Mexico's health system is similar to the one in Argentina. And so we want to learn from all of the different programs in the different regions, in the different countries. So we need to look at each other, at what we're doing, so that we can set the next steps towards elimination of hepatitis.
Obrigada, Dr. Marcelo, pela apresentação. E em nome da doutora Ana Cristina, que é a coordenadora dos programas de hepatite.
On behalf of Dr. Ana Cristina, as Dr. Jason Pereira, who is the director of the department, it's a huge opportunity to be here to speak about our advances and also our challenges. And this is a very special for hepatitis C. We were together last July, and the document was published, and we hope to bring this discussion to the area for us to go on with this until 2030. We are going to speak about this policy about viral hepatitis in Brazil, and I would like to mention the Brazil, which has a continental size, is the sixth country in the world, sixth largest in the world, and in territorial area, it's huge. It's the first largest in the world and has so many differences. It needs one look for each territory and brings us a complexity when we speak about the management of the health system. We have to suggest public policies to face the challenges, health policies to be adapted and applicable in a country in the size of Brazil. And before mentioning the hepatitis C, I would like to mention our unified health system, because we are proud of it. And for those who are really very proud of this accomplishment. The unified health system is an accomplishment that our people did. In 1988, in the federal constitution, we had the right to health. So as managers, we have to think about public policies to guarantee our right to health. In 1990, we had the organic law based on three pillars: universality, integrality, and equality. These are free services which are free of charge, and people who have access to the system, and those that can be, and we have also a complementary health. But the study in 2019, 71.5% of the Brazilian population depends exclusively on SUS. Speaking about the National Viral Hepatitis Program, next year we'll have 20 years of this program. It was created in 2002. There is a federal normative establishing the responsibility. We have one coordination and 27 state coordinations in each Brazilian state, and every municipality, 5,570 municipal coordinations to fight against hepatitis. For us to work together, we have commissions at the municipal level, state level, and national level, and we can discuss politics, what we call tripartite commissions, to publish the guidelines, to implement strategies to face viral hepatitis in the country. Here, it was very interesting to show you what are the exams, tests, and how can we provide this through we have the medicine tests and other health impacts. We have rapid anti-HCV tests for hepatitis C and hepatitis B. We have conventional viral load and rapid hepatitis B and C tests. We have HCV genotyping. We have also hepatitis B and C medicines through the Ministry of Health, as well as prevention devices like male and female condoms. So have the possibility to negotiate, and we distribute these for all states and territories. In a complementary way, we have some actions through a list with several different values. The Ministry of Health give us values for states and municipalities to complement this and can fund this in their territories through their needed actions. And here we have it's important to see the difference of hepatitis cases in Brazil. We have the South area, and also we have health industry with population, and also they have detection test area, like we have the North area, the Northeast region, and also the index of new cases is largest, not because of the population profile, but this can be influenced by the difficulty of access for diagnosis and treatment as a whole. So from here, we can see that there is a meaningful difference among the areas, and we demand that we have strategies, different strategies when we're speaking about treatments.
Aqui a gente traz pouquinho sobre o nosso plano nacional.
Here you can see the plan. We have an agreement with all those, and from this, they could establish some levels, how diagnosis can be. For example, in 2021, it was established that we have to address more than 15 million people, and we have to treat more than 50 million people to eliminate completely hepatitis by 2030. This was agreed among the three government levels, the federal, state, and municipal level, to follow the evolution of these policies.
E aqui eu trago para vocês
Here,
os protocolos clínicos e diretrizes.
We can see the clinical protocols. These documents, they orient all prevention with hepatitis, and they should determine for this, and when you speak about treating people, the first protocol that started to see some was in 2015, but because of the price we had concerning the drugs we had and the impact we had, this protocol would prioritize for people in advanced phases. So we could insert the drugs, and we had to limit this for those who were in some advanced phases. In 2016, we had the registry of new drugs. In 2017, we had the 3D with a new protocol version. In 2018, they had the universality of the treatment, so they could have an impact concerning drugs to do this universally, allowing the treatment for all people, independent from the
Em 2019, a gente mudou a estratégia de aquisição de
and we changed the strategy, we changed the drugs, and
passou a fazer a aquisição pelo
we should do the result of this, as the majority of them, we started to buy drugs using the same therapy And for those that had the least impact on the system was the vendor and the provider to Brazil.
E essa mudança na maneira de aquisição, permitindo uma
This
concorrência
change
trouxe resultado muito importante para o sistema de saúde, porque garantiu a sustentabilidade do programa e do
This
fornecimento
is the sustainability,
da diminuição de preços. A gente teve, então, a primeira compra de
the first buy
em 2015 e 2016 também, com custos que chegavam próximo aos $11.000, custos médios de tratamento próximo aos $11.000. Esse custo reduziu
this
pouco
cost was reduced.
3D no Sistema Único de Saúde. Em 2018, nós tivemos a
In
inserção de
2018,
que ampliou a concorrência e trouxe também um benefício para o Sistema Único de Saúde. E quando a gente mudou de vez a forma de
and when it changed
aquisição dos medicamentos, fazendo a concorrência pelo
to acquire drugs concerning the therapeutic results,
$32 por tratamento completo. Esse valor de 2019 ele teve um incremento porque nós precisamos naquele mesmo
we
ano
had the increment,
de glecaprevir com pibrentasvir, que naquele momento era o único medicamento indicado para tratar pacientes com doença renal
and
crônica.
this is for those who had chronic kidney disease.
Nesse slide a gente coloca
In
a
this
série
slide, we can have the historical.
Então, desde 2010, quando as alternativas terapêuticas ainda eram interferon, ribavirina, bolsiprevir, telaprevir, e 2015, quando o SUS passou a fornecer os DAAs. Então, nos anos de 2020 e 2021, a gente vê
In
uma queda.
2020, 2021, we had a drop. We had the pandemic's impacts. People didn't go to hospitals, and the system was dedicated to combat the pandemics. So we are now trying to, it's hard, it needs a gigantic move to look for these patients again. So we are in this process to have the strength we had in 2019 to improve the situation. Concerning our goal, concerning the elimination target for this, we have less treatments, and the goal is to increase the need for new strategies to treat these patients.
Então, em relação à meta de 2030, nós já cumprimos 25%.
Concerning the 2030 goal, we are in 24% of the number of treatments we should perform. We are 1 and 5 months behind, so we have a larger demand to eliminate hepatitis in Brazil.
Aqui eu trago a estimativa de casos de hepatite.
Here we can see the estimate of hepatitis C. We have the prevalence and treatment. We can see the from 15 years old to 9 years.
A população geral, a gente tem uma prevalência de 0,5% e HCV, uma prevalência de HCV.
And we have also a HCV of 32%. This, we have been treating 140,000 people with this slide shows us an important vision since 2016, how they were inserted, and we had a decrease in the number of deaths from 2016 to 2019. And this is very important when we have innovation and to reach the goals concerning elimination. Here we can see the reported cases of hepatitis A, B, C, and D. For hepatitis C, we had a reduction of 33%, and this replicated for all hepatitis, and this shows the dimension of this COVID impact and how we can think and rethink, review our goals, review our mathematical models for us to have this and to go on with our goal until 2030. I know that here our focus is hepatitis C, but the vertical transmission, we have to have a different look concerning for hepatitis B, we have vaccinations, drugs, prophylaxis that contribute to the decrease of these cases. And in Brazil, we have the indication that this is the universal testing for pregnant women with hepatitis B and C. For us, in the opportune moment for hepatitis C, we cannot treat pregnant women and newborn babies. We have to follow up these women and also the newborn babies. And in Brazil, we have to advance with this. And the goal is to eliminate. And now I have some projects that we are trying to implement. The oral fluid test to test hepatitis C. Our intention is to test this in different populations. São Paulo State, our intention to test people that drug and alcohol psychosocial care center. In Pará, we intend to help the riverside communities and also giving training to the health professionals, and also Rio Grande do Sul. Our intention is to test the strategy for people in prisons, and here in Federal District, it's to improve the primary care services and to develop and apply vaccination for this population that don't receive primary care services. And also for hepatitis elimination, we have the NGO's public notice, hepatitis C microelimination in dialysis services. And those that are in people that, and also strengthening the role of nurses in viral hepatitis elimination to improve the diagnosis and the treatment of viral hepatitis. Thinking about this, the strategy in Brazil to improve the diagnosis is decentralizing to primary care. We have some centralized cases, hepatitis C. Really, we have a work and we have a line of care to guide the care of people with hepatitis B or C in primary health care. And when one identify these people, we have to guide the care of these people. We will publish this line of care and include it in our primary health care, and also invest in the training of health professionals, nurses, physicians, health professionals in general. this capacity building to qualify primary care health workers in the care of viral hepatitis and nurses in viral hepatitis care. Here, we can see the strategies in development. We have to qualify non-specialist professionals with a focus on nurses and physicians. We have also the agreements between management levels for the implementation of strategies for the elimination of viral hepatitis, enable the use of modern objectives, simplify technologies and protocols focused on expanding comprehensive care, mobilize actors from medical and civil societies, universities, and managers to implement actions to combat hepatitis, and the establishment of actions in partnerships with the PNI for strategies to increase the vaccine coverage for the hepatitis B vaccine with actions aimed at different age groups. Thank you very much.
Thank you so much, Doctor, for your great presentation. I don't believe we have any time for questions, but we encourage everyone to leave their questions on the chat where we will be taking care of them. We are now going to hear from Dr. Cielo Janet Rios. She is the specialist on ITS, HIV and hepatitis. She works in the Direction of Prevention of Hepatitis in Colombia. Doctor, thank you for your presentation. Go ahead. Thank you so much for the invitation to join the coalition. I think you can see my screen, right? Okay. What do we need to move towards the elimination of hepatitis in Colombia? First of all, let us understand the charge of this disease, hepatitis C and B in Colombia. We had two different inversion cases of hepatitis C and B in Colombia. On the left, we can see the inversion of 2017, and where we see that the prevalence is 0.66 with an estimated cases of 325,000. We did the same exercise for hepatitis C on 2019. The prevalence was 73.73% for all age groups. But we believe that people under 24 years of age is lower than 24%, and it could reach 1.5, 1.6% in people from 50 years of age and onwards. And this was thanks to the vaccination program that has been implemented in Colombia for more than 25 years. The number of deaths from hepatitis C and B because of hepatic cancer, cirrhosis, and etc., we believe that there is 25% of deaths that could be linked to these two different events. But we see that it has been stable throughout the years when we compare to the total deaths that we have from cirrhosis and hepatitis in general. Regarding the notification of cases, Colombia has a registry. We have a compulsory notification for hepatitis B, C, and D. Also for hepatitis A, but I'm not putting the statistics here. For hepatitis B, for instance, from 20 to 2020, you can see that we have a lot of fluctuations. Some of them has to be with the reduction of cases, but in the last years, we see these trends downwards. Of course, 2020 was a year where, because of the pandemic, we didn't have so many cases. Regarding hepatitis C, we had an increasing but stable curve. And then we started the centralized process, we see how cases increase, and that doesn't necessarily mean that these are new cases. Some of them from the beginning were people that already were diagnosed, but they hadn't been notified. We can see how this is increased, and then we see a reduction in 2020. With the different exercises that we've carried out, we believe that we have a 9% prevalence of people of hepatitis B and 13% for hepatitis C. Regarding treatment, we carried out an exercise in 2019 where we identified 21,000 people and 4.8% were receiving treatment back then. Remember that not all patients with hepatitis B need treatment. And then this is the group of people that were co-infected with HIV. We had identified 4,000 people, 648, and 40.2% are infected or co-infected. And what we had to do is to strengthen our strategy for this population. This is information on chronic hepatitis C. From the centralized purchase of drugs, we established as well an information system that would allow us to follow up people with hepatitis C. And we've observed that at least from 2019 to 2020, we see women that are diagnosed, women that are diagnosed at over 59 years old, whereas young people from 25 years old have an early detection and a peak between 30 to 35 years. And this is where we have a lot of men that have been diagnosed with hepatitis C. The explanations are the following, that this group is the one that has been receiving more triage, and because we have a concentrated pandemic, a big portion of people are men that have sex with men, and that's how we believe that we have this transmission. And probably from this age group, this is people that use drugs and they inject drugs. From the centralized purchase of drugs, we see that there is a number of cases that have a diagnosis under a year. We see an increase. In 2019, it was 63%, and in 2021, on up to June 2021, we had 77.7%. So we are improving our early detection of people, and they are receiving treatment earlier on. So this is a great progress. So from the centralized purchase in 2017, we have a registry of the total people enrolled. This is the information system that are having treatment. We record more than 7,000 people, and from there 2,422 have received treatment. That is 86.7% of people enrolled in the program, and they were enrolled because they were already receiving treatment. To the right, we have the sustained viral response and how we are having a similar response through medication, with 97% for patients that are receiving treatment from the centralized purchase. So those patients that do not benefit from the centralized purchase are very few, because most of the patients are patients that have had hepatic problems that were significant. Most of the patients fall within the treatments that are offered through the centralized purchase, which is 2,225, which is 91% of patients that are receiving treatment. This is a very complex table, just highlighting that for hepatitis B, the risk factors are people that have several sexual partners, and for instance, men that have sex with men, people that say that their partner has hepatitis B. And with that, we reinforce the theory of sexual transmission. And these are the different risk factors per population. So we have people that have multiple sex partners, and people that use drugs and inject drugs, which is 5.7%. And like I was saying, men that have same sex with men, which is 25.7%. This is the percentage of people that have hepatitis B positive tests and that have received a liver transplant. As cases increase, we see an increase in the people that have been identified with hepatitis B, but it has been stable for the last year with a trend for a reduction. And for hepatitis C, we see that this is a significant number from 2015 to 2018. And since 2019, we see a slow decrease. We were not able to say if this is because of the treatment, but the numbers are encouraging. Talking about cost, the black line is the baseline. So we believe that every year, hepatitis B costs around 400,000, 370 million pesos, which would be $121 million. And for hepatitis B, it would be $278 million USD. Vis-a-vis the total of population. And we did this so that we can design some elimination programs. So since 2014, we have created a national plan for the control of viral hepatitis. This is a program that went from 2014 to 2017. And in 2018, we unified our plan and we call it the National Plan for the Response to ITS, HIV, TB, and hepatitis B and C. And this is a plan that goes from 2018 to 2021. On this same period of time, in 2016, we issued the first guidelines for the clinical practice on diagnosis and treatment of hepatitis B. We did the same for hepatitis C. This guideline was updated, and we have a guideline for treatment based on the OMS, WHO recommendations and PAHO recommendations. And then we have this strategy for the elimination of the transmission of HIV from mother to child. And this is a plan that goes from 2019 to 2030. Centralized purchase of drugs for hepatitis C began in 2017. By 2021, we've already bought more than 1,000 treatments. This is the total treatments from 2017 to 2021, and we've been able to save $450 million pesos, which is about 147 million USD. And we've saved money because in 2016, we believe that the cost per patient was around 32,000 USD, and the cost has been reduced by 2021, which is a total for people, for each person is around 4,000 USD. We have a treatment available and the percentage of coverage, the health insurance of Colombians is 98.7. So treatment is available for almost all of the patients. There is just a few people that do not have insurance. And we talk about Colombians because migrants that have received papers in Colombia are also receiving treatment. And for the other people that are migrants and do not have papers, they are not registered by the system. We've also made toolkits for the community work on hepatitis. So these are some screenshots of a strategy that we've developed to educate on the prevention of transmission. And below you see, for instance, the cover, the poster for education on pregnant women. We've also covered vulnerable population for vaccination. We work specifically with men that have sex with men, the transgender women, the sexual worker, the people that you inject drugs, and people that live on the street. By 2021, vaccination is available for all these 5 different groups of people. COVID has made it more difficult for us to continue vaccination, but the program goes on. We have an EMO vigilance system from the National Health Institute. So we have the report of donors. And so when somebody goes and donates blood, they can find out directly if they are positive for hepatitis. From the centralized purchase system, we've strengthened the information system. Civigila, which is this form over here, which is the compulsory reporting system when we identify a case of hepatitis. Then we have a follow-up of patients, RIPS, where we report treatments and tests, and MIPRES, which is the system that allows distribution of drugs. I would like to talk about the priority, the first activities or the activities that are a priority for us. So triage for HIV, hepatitis B, hepatitis C with vulnerable populations. And we also have the promotion, the maintenance of health route, which is something that is aimed at all Colombians, and we have different age groups, and we do a rapid test for people that are at higher risk. Specifically for hepatitis C, people over 50 years needs to receive one test so that we are aware of infections. People that use drugs as well, and other criteria that are described in this technical guide. This is a table that shows how in the recent years we've increased triage compared to when we see 2017, 18, 19, we see that there has been a change in the percentage of 20.2, and on 28 to 2019, we've had a change in the percentage as well. And we see how we've also increased the use of rapid tests and the lab tests. Through this decree, we include different profiles for the rapid test of HIV, hepatitis B and C. We are right now carrying out the HIV, syphilis, BHP and BHC rapid test. This is the amount of samples that we've taken. And of course, we use the International Day of our hepatitis awareness to carry out education for the community. These are some of the samples that we did for some of the materials that we prepared for last year. And we've also developed a specific course for general practitioners and other healthcare professionals. And we are working with PAHO to have this primary care attention for hepatitis B and C. As you can see, we always try to coordinate the different activities. What have been the different challenges to increase detection? Well, the lack of information in the community, lack of knowledge of the algorithms, that not a lot of the tests are available. The competence on the priorities of public health and etc. COVID has also affected our work. There were some delays on the tests, the follow-up that were needed to receive treatment. And even though we carried out our program, we were able as well to have telemedicine meetings.
Con los mensajes clave, por favor.
Cielo.
Doctor, could you just move right away to the key messages?
Sí, para cerrar, básicamente, pues...
Debiéramos ir cerrando, Cielo, para dejarle tiempo a los panelistas.
We need to conclude, Cielo. I'm working on that. These are the different scenarios. And then we still need to work on triage to achieve reduction of the costs, simplify attention specifically for vulnerable populations, to have prescription by the family doctors, and to do the different adjustments that are needed to achieve the goal. Thank you. If you have any questions, please leave your questions on the chat so that we can respond to them. Thank you for the presentation. And we are now moving on to the panelist section. We have Leandro Sereno from PAHO, who is leader of the HIV unit, TB, hepatitis, and other sexual transmissible infections. He will talk about the need of detection in Latin America. I'm going to share my screen, and I have a few slides that I would like to show you to talk about the different activities that we're carrying out. I want to thank the invitation of the coalition. Dr. Ruben Mallorca was the person that was invited for this session, but he was unable to attend this meeting because he had to take care of some urgent matters. And I am the regional lead for the Americas in Washington. And so I want to talk about some of the activities that we're working on. We published at the beginning of this year the Global Progress Report on HIV, viral hepatitis and sexually transmitted infections. We updated figures and different status of hepatitis B and C in our region. And we see that the figures are steady. We've been able to make some progress on the strategic information. We created and generated information to estimate the charge of the disease. Hepatitis C, we have almost 5 million of infections or people that live with chronic HCV infection, and we have 5.4 million of people with chronic infection. And around 10,000 new chronic infection and 23,000 hepatitis B deaths. This is the coverage in the region, something that we also publish in this report. We have the 18% of diagnosis in the region. 20% of people have been diagnosed with hepatitis. This could be a subestimation because we've been able to identify people that wanted to donate blood, and we were able to identify them as hepatitis patients. But sometimes a diagnosis doesn't mean that they're receiving care. We need to take care of this matter. And this is treatment as well. For hepatitis B, as you can see, is only 3%. And for hepatitis C, we have 22% of coverage because of the progress made by the US and Canada and some other countries that have been advancing in treatment. We can mention Colombia and Mexico. We've also working on the strengthening of mortality data. We've published this guide to help countries to estimate the mortality rate in their countries. Mortality is one of the indicators that defines the elimination of hepatitis. We've seen many countries having some issues in reporting these indicators. And with this protocol, we aim at supporting people to have an estimation of the proportion of HBV and HCV infections in patients with cirrhosis and HCC. We also want to strengthen the surveillance system and detect failures in the coding. For instance, people that died of cancer do not have a diagnosis of hepatitis in their death certificate. So we want to improve this, enhance this information. We also have the public health and economic impact of hepatitis elimination. We also did in the investment case for hepatitis B and C. We carried out some inversion studies, Mexico, Brazil, Colombia, Chile, Peru, and Ecuador, who have concluded their analysis. And I think that this information will be very important to move towards the elimination. So these are the figures from these different countries. Peru and Ecuador are concluding their analysis, and we are working on other countries because they've expressed their interest on doing these inversion studies, but because of the pandemic, we haven't been able to move forward with that. We also have specific activities on the Andean region. We have a project that is called the Andean Hepatitis Elimination Project that aims at supporting the national responses. The purpose is to support countries of the Andean region to accelerate the response to viral hepatitis. This project has received an award, and we also have the support of PAHO in the implementation of this project on the countries of the region. The contest is because we want to build on and strengthen the agreement established by the Declaration of Santiago on hepatitis. We had a meeting on 2019. Chile convened the different leaders in the Andean region, and they agreed on signing an agreement, and so that we can have this project. And the project is the result of the agreement, and it works on advocacy and awareness, national hepatitis policies and planning, and the access to diagnosis and treatment. This is a very ambitious plan with the participation of different actors and partners, with the support of PAHO and the support of specialists that are also taking part in this program. And as part of the access to diagnosis and treatment, we have the PAHO Strategic Fund. So for the different health minister, there are some price negotiation on long-term agreements with providers, medicines and diagnostics, and a constant review of eligible products and support demand estimation. You can see some of the costs here, and you can see how some of these awards are available for some of the countries. Patents are a limitation or a barrier, and so we sometimes need to use original drugs instead of generic drugs. For instance, sofosbuvir. But if we don't have these limitations, then we can spend $9 for complete treatments of hepatitis. And then we have the support of the PAHO award to reinforce the purchase of the different drugs. Very quickly, we have published the framework for elimination guidance for country validation of viral hepatitis elimination. We talk about the different strategies, tools. We are reviewing this report. We are going to carry out the pilot project in Brazil, just to make sure that the criteria work. And this guide includes the absolute targets, because we're no longer talking about the reduction, but we also want to talk about the absolute targets that each country has to achieve. And this is important because for some countries it is difficult to define the target. And so we believe that absolute targets will get rid of the situation. And just to close, we want to talk about the elimination initiative. It is a bold pathway forward. It is a framework from all of the members that so viral hepatitis elimination is within a broader elimination agenda of ending a range of communicable diseases and related conditions in the region. It builds on several achievements of the region of the Americas. We share experiences, we share resources where we can enrich our knowledge. We have links over 30 global and regional strategies and plan of actions into one structure and unifying framework, and it provides also the framework for the attainment of the 2030 Sustainable Development Goals and the health agenda for the Americas. We use a patient-centered method. Thank you. Dr. Solange is now going to present. She is the co-founder and vice president Sorry, she is the leader of the National Program of Transplant. You have the floor. Thank you for the invitation. So we wanted to talk about the situation in Uruguay. Uruguay is a very small country. We have a total population of 3,474,000. The prevalence is 0.7. We believe that 24,000 people are infected, but we do not have prevalence studies. The incidence of the notification is 391 cases in 2019 and 237 cases in 2020. We know that the compulsory reports since the pandemic they failed. We do not have information on mortality by cirrhosis, but we also have information on transplant and we have some information on cirrhosis. We have a integral health system in Uruguay. And for serology, we have PCR, which is compulsory in some of the countries, $70 USD. And the quantitative is 135 US and the genotype is 160 US. We have a national fund for resources for the general purchase of drugs. From 138 treatments, only 114 were approved, and in 2020, 105 out of 136 treatments were approved. The patient has to pay for the PCR test, and that's why we don't know how many people have been healed from the disease. We have a universal coverage in Uruguay, and in 2017, we had the introduction of antiviral treatment, and we started using also genetic treatments. We do not have a genotype since 2020. We do a APRI, and we continue with the determination of the viral load. Some people do not respond to the question sometimes. We see new infections since from 2015 to 2020. It seems that there is a decrease. We believe that there is a decrease because of the pandemic, but we see that there is a plateau on the patients that need transplant. We worked on the policies for the elimination of hepatitis C with the Ministry of Health, the ITS HIV/AIDS program, and the National Committee for Public Health. We published a first national guide on how to manage viral hepatitis B and C on the different care systems and the attention. We have the participation of technical equipment from the national program and UDELAR. This is the universal test is compulsory for people over 40 years of age. We have a PPL test. We are also moving towards a test for the pregnant women. And we are planning on having FibroCan, and that this is covered by institution and not patients. Next slide, please. What are the different challenges and strategy for the elimination of hepatitis C in Uruguay? We need to overcome the gap to develop a national program for viral hepatitis. We're always grateful for knowing experiences in other countries. We need to strengthen strategic information, and from that, we are also working. We're seeing if with the support of HIT, we can start having the support from authorities to identify patients and to guarantee access to treatments. So with a little bit of luck, we'll be able to move forward. We had a partial support that would allow us to move forward. Thank you. Thank you, Doctor. Marcelo, you have the floor. Thank you, Solange. We are going to ask Dr. Patricia from the World Hepatitis Association to give her presentation. Thank you so much, Marcelo. Good morning to all of you, and thank you for the coalition for the invitation to be able to share some of the experiences with you and perhaps to strengthen the exchange of information. I want to congratulate the work on the different countries. I am pleased to see what has been done in Mexico, Brazil, and Colombia that are moving forward, and hopefully we'll be able to catch up with them one day. We are working towards the elimination. We're lagging a little bit behind, but we're moving forward nevertheless. These are the main achievements for Guatemala. These are important milestones, even though we haven't reached elimination. We are able to do 100% of the triage when people are donating blood. And the only thing that we haven't been able to achieve is to have all donors to be volunteers. We only have 5% of volunteers, the rest are preposition donors. And since 2004, we do a triage. So the treatment with direct antivirals of direct action is something that we have been doing since 2019, but we can only offer one treatment, sumoslimab and patasvir. We still do not have the other treatments. We don't have alternative treatments and treatments that we can offer when the one that we are giving is not working. All of the triage tests are free of cost because the country has purchased these tests. During the pandemic, we were able to do several things during the pandemic. We have published the guidelines for the implementation of integral care, and we are working on training the staff. Civil society has participated in the technical table from the beginning, from the formation of the technical table, which was in 2017. So we can say that our voice has been heard. Academia has also participated in training for the hepatitis C, diagnosis and treatment. This is the only university, state university, that has given training on hepatitis C for all health professionals for the MOH in Guatemala, and also for Social Security and the military. And it had to do with everything that had to do with hepatitis C. And 2019, we give training for treatment and diagnosis of hepatitis C for those who work in primary care. Some of these trainings have been given in person and some online. From the first World Hepatitis Day, we have participated. We have raised awareness on hepatitis. And in 2018, we were able to join the World Celebration. And we gathered with all the actors, Ministry of Health, PAHO, San Carlos University, the Society of Doctors and Surgeons, and other societies. So it is a very important day to raise awareness on hepatitis. This is the guide or the guidelines for care. In Guatemala, we still do not have a national plan for hepatitis, but having a guideline is important because it was done with participation of many actors. See whomever participated here. It's on the back of this guideline. We had the support of the army. We also had the government participating. The University of San Carlos, the GI Association, and the Gynecobstetrics Association, the Guatemalan Association of Doctors, and the International Hepatitis Association, PAHO as the international organization, amongst others. This guide will talk about prevention, diagnosis, treatment, and follow-up at all of the life cycles, as it is said on the guide. So this is the first step to get this triage at the national level. These are the objectives for Guatemala. You will be able to find them in the guidelines. Even though we still do not have a national plan, we have set these objectives. These are in line with the world strategy towards the elimination of hepatitis. The indicators are 90-90-90. 90% of people that have a risk factor have been triaged. And from these, 90% get a diagnosis. And those who have been, 90% of the diagnosed people have received treatment with direct antiviral. And we hope that 90% of the people treated with direct antiviral will have RVS12. Diagnosis capacity. So this is the map for Guatemala. See how in the whole of the territory, we have established capacity to do rapid tests for the triage. And to do diagnosis with viral load, we have the national laboratory that is in the capital city, and we have 16 units of integral care. They go by the name of Y, where we take care of people with HIV, and they already have gene expert for the viral load. 2 national hospitals that are Y have COVAS. But this installed capacity of these Ys for HIV is what we have used to be able to do a diagnosis of hepatitis. The only issue is that these are only available for the 3rd level of attention. Even though we have 16 in the whole country, some parts in Guatemala need this capacity and we do not have it. So we have 16 Y, 2 of them are in the capital city, but they are all in hospitals. We don't have anything at the second or the primary care. secondary and primary care. And we are also facing the following issue. Right now, we do not have reagents for the viral load at the WISE. Given that we do not have them, we cannot propose diagnosis at the country level, and there isn't a local demand for treatment because we haven't diagnosed any cases. And as you see, only 2 hospitals in the city have them. So we need to send people to a higher level, to hospitals in the capital of Guatemala. And these hospitals are the only ones that have reagents for viral load and that can offer treatment. Roosevelt Hospital is a very big unit that has purchased treatment for 1 year. So MHA is not able to buy more because one hospital already have it. And the problem is that some patients have to pay out of pocket to go to the capital to receive treatment. So that restricts access to care for some people. Nevertheless, we have made some progress. January this year, we started already with the triage in the different units and all the different services. So we have begun with triage of hepatitis B and C. We were able to conduct that for pregnant women, but we're including for everybody because we believe that this is a reporting instrument. And therefore, from January to August 2021, we have been able to conduct the HIV test together with the triage for hepatitis B. But we still have a lot to do for hepatitis C, even though we have the test. And we're not buying as many tests as we buy for HIV. And not all hospitals report. So the health services for primary and secondary care report to the system, but hospitals do not report. So there is lack of governance. Also, at least Roosevelt, which was a hospital that was not reporting, started doing so. We do not have surveillance for epidemiologic. And we believe that this is because we don't have enough staff that will be able to take care of the vigilance, the surveillance program. So we have a surveillance program for HIV and for pregnant women. But that's why we're lagging behind, because we do not see enough tests, and the same is happening with pregnant women. With pregnant women, we did less than 1,000 tests. And in general, only 53% of pregnant women have been triaged, and only 53%, only 24% have been triaged for hepatitis C. We already have established that this is something that we have to do. The CDCs at the US have established that this is necessary, and many countries haven't done so. At least we have started doing, but we still need more tests and raise more awareness so that people go and get tested. Repercussions of COVID-19. Well, we do not have enough human resources. Everybody is busy trying to join the COVID response, and so they do not have enough time, and we do not have enough staff to raise awareness on hepatitis B and C. We don't have a lot of money. We've never had a lot of money, but with COVID, we have even less. Everything slowed down because everybody is busy with COVID. They have to replace people, they have to join forces, and there is a restriction on the services. A lot of external and outpatient services have been closed, and there are some clinics and hospitals are only giving emergency care. And so that's why there's lack of attention of cases. The severe cases, the chronic cases are not receiving proper care. And we want to buy a FibroScan for a national hospital. The GI department bought it, but because they don't offer any outpatient consultations, we are not being able to use it as much as we should. We have a reduction on the search of active cases, and we have not been able to work on proper awareness campaigns because everybody's concentrated with COVID. So these are the challenges that posed COVID-19. So we've already have opened the door for hepatitis, but we haven't been able to start working on it. So this is the work ahead. We need to implement the guide so that we have supplies, so that we can provide them to all of the services. The guide says that all services must be accessible, that there should be diagnosis at all levels, at least secondary care, or at least at the Ys that we mentioned, the units that we were mentioning. Tests should be more accessible. Today, they're restricted to some services, and with that, we will be able to supervise advancement. We can identify gaps and opportunities for this program. We also need to train staff, and we need to do a national campaign. But we've already started. We have a guideline. So the Ministry of Health has to decide which will come first. And they decided that they wanted the guideline first. Social insurance always gave treatment for HIV and people with hepatitis. And the MOH did not have it, but now the social insurance doesn't have it either. So people from Social Security have to go to the Ministry of Health to receive treatment, given that Social Security hasn't been able to buy those treatments. So we need to improve this, and we need to train all health professionals on primary care for diagnosis and treatment of uncomplicated cases. We shouldn't send these people to tertiary care or third level attention, because they will have to pay out of pocket for transportation, for meals, for accommodation. We know that there is a lot of inequality in Guatemala, and many people are poor in Guatemala. So we need to work towards the universal care. We need to do a lot more awareness, and we need to be champions of hepatitis so that we can get more resources, financial resources. And we also need to disseminate information so that there is a surge in demand of tests. I represent the civil society. I have been working on this field for more than 20 years, and I have done a lot of awareness. And I believe that we have done a lot of things. For instance, we have treatment for everyone in the country, regardless of their social position, whether they have social insurance or not, and regardless of how severe the disease is. So it is important to offer this, and it is important that we're able to give diagnosis and treatment for free. So given that we are on a pandemic, I think we've done a lot, but we continue to move forward so that we can attain this goal to control, to curb transmission, that people receive diagnosis, treatment that is efficient, and that everybody has access to that. Thank you so much for your attention. I leave you my email in case you want to reach out to me. Thank you. Thank you so much, Patricia. Great presentation. Now we are going to listen to Maria Eugenia De Feo Moyano, President of Hepatitis C Foundation Without Borders. You have the floor, Maria Eugenia. You know that
everyone that is on Zoom always is muted always, but I think I'm okay. I think you can hear me, right? Great. Okay, thank you so much for this invitation. Thank you, Coalition, and thank you. I mean, I feel proud to be invited and to be able to represent the civil society of Argentina. I've been working on this field for 20 years, so I believe that this is a great opportunity. It is with great pleasure that I present to you the progress made from the patient's perspective. I think we will be talking about the experience, and it is important to talk about the figures, the statistics. Hello? Hello, can you hear me well? Should I go on? It has been a great presentation. I've liked the presentation of all of the countries. Hello? Hello? Well, I'll continue. I'll move on. I think you can hear me well now. Our country has a program for viral hepatitis, and this exists in 2012 with an external committee that is made up by the civil society, the academia, authorities, and people from the federal hospitals. With this program, we want to curb and work towards elimination of hepatitis. We've made great progress, for instance, the donation of safe blood, having an effective vaccination campaign, and having access to diagnosis and treatment of viral hepatitis. We want to ensure access for quality in attention. This is the axis of our work. We want to raise awareness, and we want at least 80% of people to be treated. This program, together with PAHO, have developed a strategic planning that goes to 2021. And they want to use strategic information on hepatitis diagnosis, prevention, treatment. In Argentina, the health system is debilitated. So some people have private insurance, some people have public insurance, and then we have federal and regional insurance. And that's why we have created this viral hepatitis program that is federal, but also we have the local programs that adapt to their local reality. And we have established a reporting system. People from the hospitals and clinic must notify of every cases, and that's how we have been able to collect data. We have indicators that have to do with the strategic information for viral hepatitis, and with that we've been able to identify the viral load in the country. We also publish a newsletter that is specific for viral hepatitis, and we have been doing so since 2017. So we know that for every 100,000 inhabitants, it went from 63 to 37%, and we can see that with the vaccination program that we have since 2005. We vaccinate people and children when they are born. We have 0.4% of prevalence since vaccination, and this is according to surveillance data in the blood bank. And we have a calendar for vaccination, and since 2012, we have made a vaccination available for adults. With that, in 2019, we reached 82% of coverage with doses for the newborns. WHO has set the goal of 50%, so we were able to reach 82%. So for us, vaccination is very important, and we're encouraging people over 20 years of age to get vaccinated. And we're trying to have universal coverage for diagnosis and for treatment. We have done more than 17,000 in 2018. We have a 0.5% prevalence for hepatitis C. We have more than 220 people affected by this disease. And we believe that around 300,000 people have hepatitis in our country. People have with universal coverage of health, 50% on the public sector and the rest on the private sector. There is a reduction on the prevalence and incidence rates from 2015 to 2019. 119 was for 2019. There was an important reduction and on the transplant rate and mortality. We have huge reduction on the percentage of the waiting list of people. Since 2017, we have universalized antiviral treatment. Everybody has access to universal and universal care free of charge. And this is thank you to the national plan, hepatitis national plan that we have. Public security and social insurance and public health has made the effort. We've also in 2019 were able to reach more than 1,500 people that were treated in the different health systems. These figures stagnated during the pandemic, but then they've increased this year. And we are not even at the end of the year. We are also treating people in prisons, and there is 3.3% of prevalence in people in prisons. We still have a lot of work to do, but we have an idea on how to strengthen strategies and how to treat everybody. The current strategies for treatment of hepatitis C and the challenges. We are promoting universal triage for hepatitis B and C on adults and pregnant women. We have the support of the Scientific Society, the Ministry of Health, and the participation of the civil society. Now we look at the adoption throughout the country. The tests reflect how we've been able to simplify our program. We have a solid strategy at the public hospitals in our country. We've been able to reduce times for consultation and treatment. We came from 7 visits to only 2 visits, and this helps reduce the load on patients because of transportation and etc. The challenge is to do the same all over the country, and that is why information is paramount. We have 2 pilot projects, a diagnosis with dry blood, and we have another with plasma. The current challenges that patients see is to have treatment for hepatitis C. We are using legislation to do so. Lack of awareness on the need to do tests for hepatitis C at the primary care. Continuous attention in all of the centers of the country triage throughout the country, specifically on the public system. Some subsystems are requiring also supplies for diagnosis. The challenge today is to raise more awareness on the need of the triage of the general population. COVID-19 has repercuted in our efforts. Just like any other country, we see a reduction on the percentage of the demand for tests and treatment, but we are working with the national system and the civil society to raise awareness on the patients that were afraid to go into the clinics because they did not want to get infected by COVID. And civil society has helped us greatly to this endeavor. We are trying to reduce inequality. This is why we are using a law that is unique in our country. So we are working on a bid that we hope will be adopted, where it includes treatment for viral hepatitis and viral diseases. And with this, we'll have a strategic legal framework for attention of people with chronic viral hepatitis. Today, we do not have that program, but we depend on the political will on legislation on this unique law and the political situation in our country. We know changes in government and financial crisis, but we believe that this legal framework will ensure access to tests, diagnosis, treatment, and all the social guarantees to avoid stigma and discrimination. The simplified diagnosis, access for treatment in the health system, the national plan for the elimination of dialysis everywhere in the country, regardless of whether people have social insurance or not. These are efforts that we're doing to reduce inequalities, and having universal coverage, we believe, will help us too. We need to integrate more the health programs, and with that, we'll have the strength we need to be able to continue fighting and continue working towards the elimination of hepatitis. Everyone needs to work together so that we can understand all of the problems, talking about strategies and all the way to the patients who are the ones who receive care. To be able to achieve the 2030 goals, we need to also assume the international commitment. Even though there is a political situation, we continue moving towards the elimination of hepatitis. And we want to help the task force and the coalition for all the support, because with that we can demonstrate that we are firmly working towards the elimination of hepatitis. Thank you. Thank you so much, Maria Eugenia, for your presentation, and also for all the work that you have been conducting for more than 20 years. I know that you have put your heart in it, and we can feel it, we can see that. And I've seen all progress made in Argentina. Thank you so much for your effort. We will not have more time for anything else. We don't have time for anything else. We are lagging behind. So we won't be able to conduct the Q&A session. There is also a questionnaire, a poll for this meeting. Please do so, and do it because we need your feedback. We can always learn so much from our activities. Sometimes we believe that we're doing the right thing and that we are responding to the people's need, and then we realize that actually we're not doing that. So be very honest on your feedback. There are a lot of conclusions that we can draw from this webinar, but we don't have time to talk about them. I just want to thank everybody, all the speakers. I feel that this was very fruitful for everyone. It is important to see what other countries are doing. Who is leading the way? Who is lagging behind? Where are we in terms of the efforts, and what strategies would better work for our countries and subsystems, like Maria Eugenia was mentioning? To be able to share these experiences will enrich us all. It will help us all to meet the 2030 goals. And there is always this personal perspective. We always have this question: what is the role of the academia, and what is the role of the civil society, and what is the role of the Ministry of Health? How can we all together work towards the activities proposed by WHO, PAHO, and etc.? I think this is key to accelerate the process for elimination. And then I want to thank John and the coalition for opening up this opportunity, for giving us this space, because with this we can reflect, we can do it in an orderly manner, we can present our different topics, and we can grow together. I take away a great experience. The key message here is team building, because this isn't something that we can sort on our own. The country alone, the government alone, the society alone. We need to do it together. John, you have the floor.
Thank you, Marcello. Thank you, Alexei, for moderating. I thank all the speakers for their excellent presentations of highly effective programs in the Americas, demonstrating the key components of effective hepatitis elimination programs, national policies, strategies appropriate for the country, targeting key populations, seeking simplified models of care to be integrated within existing health systems. Truly great lessons to be shared and adopted elsewhere. The goal of this webinar is to promote this community of practice throughout the Americas. Please let us know in our evaluation what are the new topics that we could touch on in follow-up webinars, so that we can really build this community of practice and work together more strongly to achieve the goals that are possible and prevent premature death from hepatitis B and hepatitis C. I want to thank you all again for participating in this webinar. We look forward to working with all of you closely as partners in the coalition and this community of practice for the Americas. Again, please fill out the evaluation form. I have to end by saying how impressed I was by the strong participation, even though we went much longer than we had planned. So I thank you all for your strong interest in hepatitis elimination. And it's this demonstration of interest and this openness to work together that I know makes hepatitis elimination possible. Thank you again for your participation, and I look forward to working with all of you in the future. Working together, we will eliminate hepatitis. Thank you very much. Thank you again, everyone, for participating. Excellent presentations, very exciting programs that I certainly learned more about, and I believe many other people did as well. So it's very, very helpful. Thank you.
Thank you very much, John.
My pleasure. Thank you.
Bye-bye, everybody.
Bye-bye. Thank you, Marcelo.
Bye-bye.
Let's go for lunch.
Ciao.
Gracias, John. Excelente actividad. Gracias.
Placer. Chao, chao.
Ciao.